All right. Good evening, everybody. We are going to go ahead and get started. My name is Lori Van Dam. I am the CEO of Susan G. Komen New England, and we are delighted to welcome you to our inaugural webinar, which this is new technology, so we appreciate your patience as we work our way through the logistics, but we hope that everybody can hear us and see the screen and also the person who's talking. So today we are going to talk about genetic testing and breast cancer. And besides me, you will also be hearing from Maya Saeed, who is the CEO of Outcomes for Me, which is a really cool app that we're going to learn a little bit more about that includes some information about genetic testing. And then we're also going to talk to Dr. Rana, who is going to answer all of your burning questions. And she is, what is your actual fancy title? Very fancy at the Dana-Farber in the clinical director, cancer genetics and prevention. This is something I should have written down ahead of time. I will make a note. Next webinar, I will have everyone's titles written down before we get started. So we're going to spend about an hour together. This is being recorded so that it will be available for playback later on if anybody was not able to join us right at the beginning. So I want to start to tell you a little bit about Susan G. Komen New England. Many of you may be already familiar with us, but in case you are not, you see on the screen kind of what we're all about. We are the local affiliate for a national organization. Locally, we are a 6-state affiliate, so we cover all of the New England area. We do not direct research that's happening in New England, but we do help to fund it. Our national headquarters is in Dallas, Texas, and they run a wonderful portfolio of research in all aspects of breast cancer, focusing especially on metastatic disease and also on the most difficult diseases to treat. We also, in the local affiliates, work to provide care and also screening for local families who are affected by breast cancer, and then also education, like the kind of work that we're doing today. So we do always like to point out that Susie Komen was a real person. She very sadly died of breast cancer in her mid-30s, and her sister promised her that she would do everything in her power to find cures for breast cancer so that nobody else had to suffer the way that she had. So we do think it's important to remember that this is a disease that affects real women and real men all across the country. It's up to us to try to help them as best we can. I'm going to go to the next slide. This is what we call our pillars, and it just helps kind of bracket the work that we do as an organization nationally. So as I said, we do research, especially into metastatic breast cancer. We're also really excited that a big research priority for us is to fund the next generation of breast cancer researchers. So we do a lot of work for researchers who are early in their career to make sure that they have the funds to stay in research and actually make those breakthrough discoveries. We provide care, which is particularly in Massachusetts, we focus on patient navigation, which is one of the very few evidence-based interventions to reduce disparities in outcomes for women of color. And that is a big way that we're going to get at our ultimate goal of reducing the number of people who die from breast cancer. And we also work with underserved patients to provide screening, diagnosis, and treatment. And we also have a treatment assistance program that allows people to get reimbursed for things like childcare and transportation in order to get to their treatments. Our community pillar is really about gathering as a group. We do a lot of events that you'll see on our website and offer volunteer opportunities, and that is an opportunity for people to kind of come together and support people who need that support. We also have a wonderful toll-free number, which is 1-877-GO-KOMEN, if I'm not mistaken, but you'll find that on our website, and that is telephone support. We have a support group for men that's on that telephone number as well. And we also have a clinical trial support hotline. So if you know patients who are being offered clinical trials and they have questions, that's a place to get their questions answered in English and in Spanish. And finally, our action pillar is about advocacy. We do a lot of public policy work to make sure both that the federal government continues to fund the critical research, but also to provide accessible care, and that is both at a national level and a state level. So that is what we're up to at Komen New England, and I am going to pass the torch over to Maya, and she's going to tell you about Outcomes for Me.
Great. Thank you very much, Lori. And again, we're delighted to be here. If you can't hear me well, please let us know. We're, again, trying this technology for the first time. So as Lori mentioned, my name is Maya Saeed. I'm the founder and CEO of Outcomes for Me, and we're delighted today to be hosting this event with Susan Komen New England. We created Outcomes for Me because we believe the system can work and should work better for patients. So our mission is really to empower every patient with their own care by providing evidence-based information. What we've done is we've built a mobile app for breast cancer patients that we launched earlier this year. The app is freely available on both the Apple Store, the App Store, and the Google Play Store. The app can help you understand your treatment options, find clinical trials in your geography, and track your symptoms. It also helps to get your medical information and medical records and interpret them, and also stay up to date with the latest news. All the information we provide is expert validated and includes the latest clinical updates. We are particularly excited today to be here because we're just launched our efforts on genetic testing. So in the profile section of the Outcomes for Me app, you will be able now to take our genetic testing questionnaire to see if you meet the NCCN National Cancer Center Network criteria for BRCA1/2 testing based on your personal and family history. So I would encourage all of you to check out the app if you haven't already downloaded it, and check out this particular questionnaire and send us feedback through the app. So with that, and without further ado, I'd like to introduce Dr. Huma Rana, and we're really delighted that Dr. Rana has accepted to join us. Dr. Rana is a physician at Dana-Farber Cancer Institute, board certified in internal medicine and clinical genetics. She received her medical degree from the Rutgers Robert Wood Johnson Medical School, completed her internal medicine and genetics training at Mount Sinai School of Medicine in New York, and joined Dana-Farber in 2012. At Dana-Farber, she is the clinical director of the Division of Cancer Genetics and Prevention. She provides longitudinal medical management of patients with hereditary cancer predispositions, and also leads multiple research projects studying various hereditary cancer syndromes. The way we're going to do the next hour is Dr. Rana will give around a 15-minute presentation, and then we will open it up for questions. We already received quite a bit of questions prior to the webinar. We'll make sure we go through them. Throughout both the presentation and after, you'll be able to submit questions through the chat button if you're on the web. If not, if you're on the phone, you can email us at breastcancer@outcomesforme.com or text to the number 860-916-4075. And again, I'll remind you when we start the conversation. So without further ado, I'll hand it off to Dr. Rana.
Literally handing the computer.
Okay, thank you. Thanks for having me. Good evening, everyone. I had no idea it was the inaugural webinar. I'm super excited to be here now, not that I wasn't already excited. So I'll just go ahead and get started. Do I? Have to.
It looks like you did it. Okay. I think you can do it. I think you did.
No, I have it.
Oh. So we'll be talking about genetic testing for breast cancer patients, but oftentimes people have questions about genetic testing for people who don't have breast cancer and have family members with breast cancer. So I certainly expect that we'll touch upon both of those things, but you can move the slides ahead now, because we'll be going over the why, what, and how of genetic testing. Next slide. And genetics has been increasingly in the media, and so you sort of can't turn on a television program or the radio without hearing about advances in genetic testing. And I think that we're actually extremely lucky that in the world of cancer genetics, there have been sort of massive shifts and changes in the availability of genetic testing and in what that can mean for the treatment of patients and for the follow-up of family members. So I'm excited to talk to you about all of this. Next slide. So we know that breast cancer is a multifactorial disease. In fact, most cancers are, and so part of it has to do with family history, environmental risk factors, genetics, aging, lifestyle, and chance. And you'll see here that family history and genetics are sort of two separate things, because there's a lot of familial breast cancer that doesn't have a quote-unquote genetic explanation at this time. Next slide. Cancer is a genetic disease in the sense that all cancers have the same genes that we have in all of the cells of the rest of our body, but they exploit certain genes. They turn on genes that allow cancer cells to grow and proliferate and invade and enter vascular structures and lymph nodes, and they turn off genes that are important in the tumor suppressor function, so things that would control growth. So every cell of the body or all cells with a nucleus in the body have roughly the same 20,000 genes, and it's a matter of what a cancer is utilizing to grow. Next slide. So within the nucleated cells of the body, there are chromosomes, and the chromosomes are made up of very tightly packed DNA. The DNA is organized in sections called genes. So a segment of DNA represents a gene, and that gene is the instructions or a recipe for making a protein. So if you think about this, the gene is the recipe, the protein is sort of the business end of things. So the proteins are what are responsible for suppressing tumors or helping cells to proliferate, but the spelling or the recipe for that protein is coming from the gene. Next slide. Oh, I guess we should have probably turned those off. We're learning more and more about how prevalent inherited cancer risk is. So this number used to be 5 to 10%. Now, if you look across cancers and you test people, irrespective of their type of cancer that they have, about 15% of them will have an inherited mutation that increases the risk for cancer. That's not a number that's specific to breast cancer, though. There are certain features of breast cancer, so breast cancers at young ages, so someone having bilateral breast cancers or triple negative breast cancers that have a greater association with genetic risk. And then there are features that are associated less often with genetic risk. However, I'll be the first to say that things like, you have to have this personal history or this family history, in many ways, that's falling out of favor. So we'll talk more about that in the discussion. Next slide. So why do we test in breast cancer? And this is partly why that's falling out of favor. One reason for testing sort of more broadly in breast cancer or in a new diagnosis of breast cancer is that genetic testing can be very much treatment focused. So it can inform surgical decision making. Someone has a new breast cancer diagnosis and they're deciding between lumpectomy and radiation versus bilateral mastectomies. Having information about whether or not they have a BRCA1 or BRCA2 mutation or other gene associated with an increased risk for a second breast cancer, that information can be helpful in informing their surgical decision making. That does not mean, though, that if a woman is diagnosed with breast cancer and is found to have a BRCA mutation, that she must do X, Y, or Z. There's still personal choice in terms of how an individual wants to be treated and what surgery they're comfortable with having, but it does allow their clinicians to be more thoughtful about the options available to them. There's also, oh, sorry, before we move on. So that's the surgical decision-making piece, but there's also treatment implications. So there are now PARP inhibitors that have received FDA approval for the treatment of metastatic breast cancers, and there's various clinical trials that individuals with various mutations could enroll in. So we're beyond BRCA1 and BRCA2 at this point. And so most individuals, at least at Dana-Farber, who are diagnosed with a cancer, have a very broad, what we call panel-based test. Next slide. So why would somebody want to know? So we've already talked about treatment. There's also other risks. So someone is has a breast cancer diagnosis, they may be at risk for additional cancers such as ovarian cancer. There may be risks to their children and other family members, including siblings. And we know that screening and prevention for many of these genes is available. And for genes like BRCA1 and 2, there are already studies that have demonstrated that if you screen for these cancers, or if you undergo other interventions, you can actually save lives. Next slide. So now that we've covered the why, we'll move on to what and how. So as I said, the genetic code is a recipe for a protein, and it uses these 4 nucleotides that are sugar-based nucleotides to help create this protein. And this is an example of the BRCA2 protein. Genetic testing, quite literally, next slide, spells out the recipe for the protein being made, and we can go to the next slide. And there's normal variability within the genetic code. So here we have theater ER and theater RE, and we all know if we see either one of these words that it translates into the same thing. And that's how much of the variability in our genetic code works. It's tolerated by the body. It's just fine at the end of the day. Next slide. A misspelling or error in the code that is not tolerated, that actually prevents the business end, the protein, from working properly. Now that's what we call a mutation. And so here's an example of something that if you tried to say this word, nobody would understand what you were talking about. So, next slide. And then more often than not, what ends up happening if someone has a variant of uncertain significance is that they have a change that we're not sure if that's that the business end is working or not working. And those changes tend to be specific to certain families, and they take a lot of time to sort out. Next slide. So Cancer Genetics Simplified, this is our textbook pedigree. If you haven't seen a pedigree in a long time, men are squares, women are circles. And this is a family that over 3 generations, there are breast and ovarian cancers. Some people are carriers, so they have a mutation, but they never develop the associated cancers, and other people who are shaded in have either breast or ovarian cancer. So this is a family where the person in the top row was a woman with breast cancer. She had a daughter with breast and ovarian cancer. Her son, who never had an associated cancer, passed down the mutation, presumably to the daughter, and she ended up with a breast cancer. This is, again, simplified. This is not what real life looks like, so we can go to the next slide. And this is what real life looks like. This is a patient that I've seen who had a thyroid cancer diagnosed at age 21 and had a really small family. And while the mom side of the family, and I've cut things off so that it's more de-identified, it didn't have any cancers, neither did the dad side of the family. But the dad side of the family is limited, as you can tell. There's only 2 men. It was her father and his brother. And when you go back far enough, you can see an early breast cancer, but my patient ended up being identified when she had a thyroid cancer, and her thyroid cancer went for sequencing and happened to identify a BRCA mutation. That's a very common mutation in individuals of Ashkenazi Jewish ancestry. And so when this was found, we had to then test her blood, and then we did confirm that she had this mutation, and it was inherited from the father's side of the family, where at first glance it really doesn't seem like a BRCA family, but it was. And she was in some ways lucky that this was identified when it was, so that she could take action before any breast or ovarian cancers occurred in the family. Next slide. So what are the risks for cancers? We know that women with BRCA 1 or 2 mutations have a high lifetime risk for breast cancer, often at an earlier age at diagnosis. BRCA1 specifically has associated with a certain histology of breast cancer, like triple negative breast cancers. There's an increased risk for a second breast cancer, and women have an increased risk for ovarian cancers, and these risks are substantially higher than the risks in the general population. Individuals with BRCA2 mutations have been found to have a higher rate of pancreatic cancers, an increased risk for melanoma, and there's this emerging data on aggressive prostate cancers in the setting of BRCA2 mutations. Next slide. What do we do about this? There's specialized surveillance. So we begin MRIs at age 25 if we know someone has a mutation. Mammograms start at age 30 and then they're done, alternating every 6 months. Breast exams are done every 6 months. Men are screened with PSAs. Families that have a family history of pancreatic cancer plus a mutation can have specialized screening through a research study. It's not an evidence-based study, so we don't know if it's not an evidence-based protocol, sorry. It is a study that is collecting evidence, but again, it's under study. And then preventive surgeries are offered to women who harbor BRCA1 and BRCA2 mutations, and we know that that's particularly effective for reducing ovarian cancer risk. Next slide. And then how, so this is sort of the final piece, as I alluded to earlier, we're at least at Dana-Farber, we're well beyond BRCA 1 and 2, and most of our patients are tested for a multitude of genes. There are at least 17 known breast cancer associated genes that are thought to have that result in a reasonably elevated, at least a sort of a doubling of breast cancer risk. And so we make sure all individuals who are having tested are having testing are tested for those, but we also do generally more expansive panels of 40 to 80 genes. Why do we do this? Because there's a similar cost and turnaround time as doing one gene at a time, and sometimes we find things that we would have never expected to find. That can be because the family history is limited, maybe the family is not that large, and we do this because we really oftentimes are trying not to miss anything in people who want information. There are some people who think that that this is too much information, and so they will scale down the amount of testing that they want, and that's reasonable as well. Next slide. And this is an example of sort of all of the names. I know it looks like alphabet soup, but an example of all of the names or some of the names of some of the routinely tested for breast cancer genes or genes associated with breast cancer. Next slide. And what's interesting is that some of these genes, like BRCA1 and BRCA2, are more high penetrance genes. That means that for an individual who carries a mutation in one of those genes, that their risk for developing breast cancer is at least 50%. However, more and more we're starting to test for genes in the moderate risk category. So that means that the risk for breast cancer is not 8 to 10 times higher than in the general population, but it might be somewhere in the 2 to 4-fold or 2 to 5-fold increase in risk range. That's still information that one can use to inform their care. Next slide. Thank you. So sometimes when we are looking for answers, we do end up with more questions. Next slide. And I'll give you some of the drawbacks. So some of these genes, as I mentioned, may not have very high cancer risks. That's not including things like BRCA1, BRCA2, or even PALB2. We don't necessarily have a very clear sort of understanding of risk must be X times higher before offering testing. I think we've moved into the realm of testing for things when there's a double the risk. I think it's also fair to say, though, that most of the people we're seeing because they either have breast cancer or they have a family history of breast cancer. And we're still learning many of these things, but what's interesting is that in the last 5 years since we've been doing this panel-based testing, while when we first started, some of the information was emerging, like PALB2 is a gene that works very closely with BRCA2, we didn't know as much about it. And over time, what we've learned is PALB2 is in the moderate to high risk category. And so oftentimes people are treated similarly to individuals who have a BRCA2 mutation. Next slide. So what's interesting about genetics is anything that I say today can be wrong tomorrow. So genetic testing is being recommended far more often than it has in the past. And I think part of the reason is because it matters for treatment. The other reason is that family history and sort of meeting certain qualifications is if you can miss people. We know that from studies that 50% of people who have these mutations in the setting of cancer, they don't actually meet the NCCN guidelines for testing. And so this has led the American Society of Breast Surgeons to state that all patients diagnosed with breast cancer, new or historical, should have genetic testing. And this recommendation, when this came out earlier this year, was extremely controversial. And I won't be getting into the controversies behind it. I think you can have a breast surgeon come and talk about that. Next slide. But the USPSTF, which is a sort of more conservative group, actually just last week, came out with this recommendation that all physicians, including primary care physicians, and really all clinicians taking care of patients, need to be thinking about BRCA mutations. And they recommended that clinicians do utilize family history screening tools, and that they consider one's ancestry. So, for example, Ashkenazi Jewish ancestry, we know that there's a high carrier frequency or prevalence of BRCA1 and 2 mutations in that population, and that clinicians think about these things when they're talking to their patients. And so I think it was a pretty landmark statement from the USPSTF, although it's something that we've been thinking about and promoting for quite some time. Next. Practical aspects of genetic testing are, is it covered, is it not covered? So private insurance has certain criteria for coverage, so age at diagnosis, number of affected family members, things like that. It varies by one's insurer. Medicare, the patient must have a cancer in order to be covered, but then they have to also meet family history criteria for coverage. Medicaid, at least in Massachusetts, it's often contracted with certain laboratories, and so it's often covered. And then most people who get genetic testing are covered, but there's also now that there are so many companies offering genetic testing, the cost of genetic testing has gone down to $250. So, and many of the testing companies, they use income criteria. So if $250 is too much, they will ask for the household income, and then they have a sliding scale. So it can be as little as $20 and as much as $250 if it's not covered by insurance. So these are not the days of $4,000 genetic testing for BRCA1 and 2, and I think many of us remember those days. So people often have questions about insurance discrimination. So the genetic information, it's actually the Non-Discrimination Act of 2008, prohibits the use of genetic test results as a pre-existing condition by employers and by health insurers. So one will not lose their health insurance based on having a genetic cancer susceptibility. Things like life, disability, long-term care, there are no federal protections for those, but in the state of Massachusetts, Massachusetts has its own laws that are that try to protect patients from having this information used against them. For those who've already had cancer, really this doesn't make much of a difference. And then so testing has traditionally been done through our genetic counselors. These are two of our senior genetic counselors, Kathy Schneider and Jill Stopfer. And the next slide, and genetic counselors are responsible for really translating what the genetic information means. And so on the next slide, they do advocacy, they help people determine risks, they educate about the genes and how this information can be useful to the person in front of them, but also for their family members. And they do provide a lot of psychosocial support throughout a genetic diagnosis. And this is how one can find a genetic counselor and be seen by our genetics team. We see patients at the Dana-Farber on main campus, as well as lots of satellite locations. And so by all means, if these things apply to you, speak with your treating physicians or clinicians, whether that's an oncologist or primary care doctor, but also, feel free to pick up the phone and come see us. And then next slide. And then thank you, and I can start answering questions. And I went over by 5 minutes. I'm sorry.
Not at all. Okay, so we're going to share this little screen just like that. And I will be the proxy for the audience. So I have questions that have been submitted in advance, and we'll just go through them. For those of you on the phone, if you do want to submit questions, you can do it by email at breastcancer@outcomesforme, that's the number 4.com. Or if you're on your phone and you want to text, the number is 860-916-4075. Those of you who are on the Zoom conference, you can use the chat box, or it looks like the Q&A box is also working. So we will start with the questions that were submitted in advance and hopefully get through those and then get on to the next ones. So our first question is, how are genetics being used for treatment for triple-negative breast cancer?
So that's an excellent question for an oncologist, which I'm not.
We'll do our best.
But I asked my oncologist friends before coming, the breast oncologists, and they said this information is absolutely being used in the setting of a triple-negative breast cancer diagnosis, because it can help to inform when to utilize platinum-based chemotherapies and also to use PARP inhibitors. And so I had mentioned triple-negative breast cancers earlier when I was going through my slides, and the reason that I mentioned that is because we know from a sort of genetic testing standpoint and genetic test results standpoint that feature of breast cancers is associated with a higher likelihood of having an inherited mutation. So there's a recent study that looked at this and found that, if you looked at 17 different genes, 15% of the 9,000 women that had triple-negative breast cancer who underwent testing had a mutation in one of those genes. And so we know that individuals with BRCA1 and BRCA2 mutations have a greater sensitivity to platinum-based chemotherapies and to PARP inhibitors, and those are not sort of standard of care treatments. And so it's valuable information. I think things like PALB2, so other genes in the same DNA repair pathway, which also confer a higher risk for triple-negative breast cancers. Those are other things that people are very interested in determining. Will people with PALB2 associated triple-negative breast cancer have, be more sensitive to these same therapies? And I think it's important that these things are studied and are evaluated and looked at rigorously, because not all of the genes in these repair pathways may work the same. So,
great. Do you want me to keep going, or you want to ask one?
Yeah, why don't you? Well, sorry, we're just doing this. We're gonna be now. We're gonna do this, and we're getting a few questions also through the
I can move back.
Yeah.
No, but you're the star.
You're the star. You want to be close, and we'll be that way. Can you still hear?
Okay.
Can you still hear us well? Okay, this is perfect.
There we go.
Okay, good.
Okay, go. Mike.
And we did, so I'm going to go through the next question that we got online. We did get a question through the chat now asking about going over the outcomes for me app. Outcomes for me, not outcomes for you, but happy to do that. We'll do that after we go through a few questions. So the second question we got is, are there any agencies in Boston, Massachusetts that provide the BRCA testing for free of charge?
So that's a good question. And I think I alluded to this earlier, where the testing is part of clinical care and is often covered by insurers now. And if it's not covered by insurers, then this is where competition in the market has been incredibly useful in driving down the prices. And so certain insurers are contracted with certain genetic testing laboratories and certain companies. But as I mentioned earlier, if some people, if someone has unmet, if the $250, which I know I keep on saying $250, that's actually not, that's not a universal cost, but it's that one laboratory decided to price this at that, and then all the other, or not all of the other, but many of the other laboratories decided to meet them at that price. And as I mentioned, many of them have patient assistance programs, and so it won't be $250 if that is if that's too much. And so some patients can have testing for free, some patients can have by working with the laboratories because they will provide some of this based on need. There's also, I think, advocacy agencies and other funds that are available to support patients in this, but it does require sort of doing some digging, and often it requires working with somebody who's in the know. So genetic counselors are very helpful in sort of laying this out, although I recognize that that's not necessarily that's not where their expertise is, but they are in the thick of this day in and day out, and they can be very helpful in helping in determining what the most cost-effective way for people to get tested is. But I don't know of any. Lori, do you know of any agency that provides a free BRCA one?
Sorry,
no, I was wondering.
You know what? I don't. I think what I suspect the person who's asking the question is asking is, can someone proactively get testing for a BRCA mutation before there's been a cancer diagnosis for free? And I am not aware of any ways that you can do that right now, but we can talk to our friends at the state and see if the Department of Public Health might have some suggestions. And we will post those on our website if we can find anything useful to provide you with.
And if there's Jewish ancestry, we do have Judy, my boss, Dr. Garber, has the before study open. So if you have one Ashkenazi Jewish grandparent, then you can be tested for at least the 3 founder mutations in BRCA1 or BRCA2 through the study called Before. It's EFOR study is the website. But again, that's it's only looking for the mutations that are common in individuals of Ashkenazi Jewish descent, and it's only the 3 founder mutations in BRCA1 and 2, not sort of a panel test.
Okay, amazing. So our next question is from someone who is describing a family situation. So the 3 generations of women, grandmother was diagnosed, it looks like, stage 4 breast cancer as the first diagnosis. The mother does not have a breast cancer diagnosis. And the question is, at what point should the granddaughters get screened? And what are the recommendations for that 3rd generation?
Sure. So how do we have the age at diagnosis?
We do not have an age diagnosis. Okay. Nope.
So I think in an ideal world, the way to do this would be if grandmom is willing to have genetic testing, to have her have genetic testing, see if there's any mutation present in the family or present in her. And then if she has a mutation, then the mother in the family may be literally off the hook, as may her children, her daughters, because if you have BRCA mutation, even if it's a breast cancer at an older age of diagnosis, that doesn't mean that there's not a driving genetic susceptibility there. And so that would be the first piece of advice or information would be get the grandmother tested. If she's not around or available or has no desire to have testing, that's her personal preference and right to decline testing, then the mother could do this based on her own mother's history. Sometimes I think we get concerned about screening, and that's if the family appears to have what we call familial breast cancer. So if it's the grandmother and an aunt on the same side of the family, and then even in the absence of a mutation, we do think that the women in that family may need to be screened differently, may need to be screened at earlier ages of onset, may need MRIs in addition to mammograms, but it requires much more information than this. So I would say, sit down with a genetic counselor, put together your pedigree, get some testing, and then you can go from there.
Great, thank you. So we do have a comment that was submitted through the chat that said around the question on free testing that in Connecticut there is funding for genetic testing for those that meet the criteria for uninsured patients. So in a few hospitals in Connecticut. So at least that's good for the group to know. The next question is more around how to manage risk. So the question is for BRCA1 positive who has had breast cancer 3 times, what is the screening recommendation for pancreatic cancer, knowing that there is no pancreatic cancer in the family?
That's a good question. I think one that comes up a lot. I think that having a breast cancer diagnosis 3 times does not necessarily put someone with a BRCA1 mutation at a higher risk of developing pancreatic cancer. So and because we don't have surveillance or screening for pancreatic cancer presently that has been demonstrated to improve or to result in early detection or to improve outcomes, we don't recommend any screening, even in the context of having a BRCA1 mutation or having 3 breast cancers and a BRCA1 mutation, because the risks for pancreatic cancer in somebody with a BRCA1 mutation are still relatively low. So in the general population, the risk for developing pancreatic cancer over one's lifetime is about 1.5%. And in a BRCA1 positive individual, the risk for developing pancreatic cancer in the absence of family history is probably in the 4% range. That's a lifetime risk. So that means that like 96% of people with a BRCA1 mutation will not develop a pancreatic cancer. And because we don't have effective screening, even though that risk may be double what the general population at risk is, it's not like we can guarantee that we would find something early.
And can you repeat, somebody on the chat is asking about the name of the before study or the website?
Sure.
They're interested. And maybe we can also follow up in the thank you email. We'll make sure we put those links. But,
sure. That's BFOR.
Okay.
So
BFOR. So
study.
Before without the E, the 2 E's. We'll make sure,
yes.
and I'll put it on the chat. It's BFOR
study.
Okay,
yes.
I'll put it on the chat. Perfect. Lori. Yes.
Okay. So there's a couple questions here that I'm going to kind of merge together to try to get at the same question. So if there is a BRCA mutation in a family, so there are siblings, one of whom has tested positive for the BRCA mutation, one of whom has tested negative for the BRCA mutation, and one sibling who does not want to get tested, the person who's writing in wonders what they can tell the sibling who's not getting tested to convince that person to get tested, and or to talk to that sibling's children about their own risk and whether they should get tested even if their parent doesn't want to get tested.
Right. So that's really challenging. And that's a situation that we see a lot of in the clinic on a day-to-day basis. And it's sort of once you know this information and have become empowered by it, it's part of the charge and we charge you with this, is to go back and tell your family members that they should be tested. But at the end of the day, you can lead a horse to water, but you can't force it to drink. And I think that you have to remember that they're within their right to not want this information. I think that all of the siblings we know have a 50-50 chance of having the mutation, and because your parents, it came from someone's parent, one of the parents, either the mother or the father, and had two working copies, and they passed down either the non-working copy, or they passed down the working copy. And so each of the siblings has 50% chance. And some people, by learning about by understanding that there's only a 50% chance and that they may actually just be off the hook, sometimes that can help them. But you don't necessarily want to convince someone to do this if they're not prepared for the positive result, because what if they do have the positive result? Oftentimes people will be motivated to get testing based on the fact that some of the things that we do in the context of a BRCA1 mutation are life-saving, so removing the ovaries. But if it's a brother and he has a 50-50 chance and he doesn't have ovaries, he may not know that the prostate cancer screening would be different. He may think, well, I'm getting prostate cancer screening anyway, so what does it really matter? I think that sometimes I boil this down to sort of a numbers argument. So if somebody has 5 kids, they should just get tested. Otherwise, they're putting their 5 kids out there to each individually go get tested, right? Because, but if they know that they're positive, then their children would need to be tested at sort of the right age. If that individual knows they're negative, then they're also removing their children from having to face this or deal with this. The numbers argument only works so if they have, more than one child. Otherwise, it's still a one-to-one of who's getting tested. It's important information to share. I think that sounds like this individual has already shared it and has already done their best to put it out there. And then at some point you have to sort of say, I'm never going to convince this person. And then the real concern is often with the nieces and nephews, and how one can share the information with them so that they know that it's important and that they can get tested despite their parents' refusal to. And that's totally fine. That happens all of the time. So in a situation like that, the likelihood that the nieces or nephews have the BRCA mutation is 25%, because it's really 0 or 50, but that averages out to 25%, and that is enough for insurers to cover genetic testing. And so for women, it's important that around age 25 they learn this information, because that's when we change our screening recommendations. For men, they get a little bit more time. It's really around age 35 to 40 that their screening recommendations change. Oftentimes, people in that age group will be getting this testing or this information, or will want to have it before having children. So they also know about the risks of passing it down.
So now just switching a bit gears, one question that we had, and I have to say I've been actually stunned looking at some of the statistics. So the actual question we received is where to find reliable genetic testing. But then I'm going to add a comment on this. So more and more I'm seeing people I know that are using the consumer tests. So for example, 23andMe, and as you know, those are checking for a specific variant of the BRCA1/2 mutation. But I know personally that I've had friends that actually are not realizing what that test is testing for versus not. And so, I want to broaden this question around reliable genetic testing to also maybe distinguish between what's in these consumer tests or not, for that matter. And when we mean really getting the test, or even the BRCA1/2 mutation test.
Yeah, I think that's an excellent point. And I think, so a couple of things. There are now numerous genetic testing laboratories that offer specifically cancer genetic testing. So they've gone through and developed assays and technologies to make sure that they're rigorously interrogating all of the genes that are on the requisition that are associated with cancer risk. So you can, so direct-to-consumer tests are different in that they're looking at various common changes across the genome. And then certain companies like 23andMe have FDA approval for the Ashkenazi Jewish founder mutation. So they have gotten approval to test for that. But if you're not of Ashkenazi Jewish descent, you're being or thinking that you're BRCA1 and 2 negative is misleading, because one is not. That test has only looked for three variants, which you weren't at high risk of having. If you are of Ashkenazi Jewish descent and you have a family history of breast and ovarian cancer, it's also important to remember that about 10% of the mutations, 10% of individuals of Ashkenazi Jewish descent who have a BRCA1 or 2 mutation don't have a founder mutation. So that's also not the best test if you have a strong family history of breast and ovarian cancer. So for example, the before study, which I talked about earlier, is looking for those 3 founder mutations, but part of what they're doing is for those people who fill out their family history and have a worrisome family history, for some of them, they're saying this is not good enough. Even if you're negative for this, you need more on the back end. And so I think it's important to recognize that not all testing is the same. One of the testing laboratories has published a paper on people who take their sequence from direct-to-consumer tests and then put it through another platform to then get a readout of their genetic test, and have been told that they have all sorts of mutations like in TP53, or they have Leaf-Romani syndrome, or they have Cowden syndrome, or a P10 mutation, and it's just wrong. It's inaccurate information. And so I think it's important to recognize that not all testing is the same, but that there are a number of testing laboratories that do high quality cancer genetic testing, but your best odds are seeing someone and getting funneled to the right testing. And some of those labs are actually creating their own direct-to-consumer tests, but we're not. But it's something that's it will increase with time. But you just buyer beware, I think, is the take home on that.
So just to add to the question, for people who are not based in Boston and can't come and visit you, they go to their primary care. Like, if you want to sort of start walking down this path, what's the best place to start?
So I think their primary care, their OBGYN, but even for people not based in Boston, there's also a great website called nsgc.org, and that's the National Society of Genetic Counselors. And then you can put in where you live, your zip code, and you can put in that you're looking for a cancer genetic counselor and the radius within miles in which you want to find someone. And then that's one way to find sort of an expert in their area. But your primary care physician or your OBGYN will be able to tell you. There are lots of resources out there, though, and it's important to sort of recognize that. I think one important thing is, not everybody has been necessarily attuned to or keeping up with all of the updates when it comes to genetic testing. And the fact that the threshold for testing has changed, and that how we do testing has changed, and also that genetic testing is not something that is necessarily cost prohibitive anymore. And so overall, I think that we all acknowledge that there are certain deficits out there. One of them is access to testing. So we know of people who meet NCCN criteria, only 30% of them get genetic testing. That's really
that's a terrible statistic.
That's a terrible statistic, but it's true. We know that people's understanding, and I mean healthcare providers' understanding of genetics is not great, and it's something that we have to work on to get everybody up to speed. There have been papers showing that individuals with variants of uncertain significance, that people can have treated them as though they have a mutation, which is not the case at all. As we discussed, variants of uncertain significance should translate into no action, because we actually don't know what it means for the most part. And so the first step, though, is identification. And I think that, as with many things, this does require a fair amount of self-advocacy, which is unfortunate. And I think this is where things like your app are helpful, because people, if they see that they meet NCCN criteria, then they can advocate for themselves, right? That, look, I meet this criteria, I should be having this. And then maybe you can move that number from like 30% to, I was going to say 100%, but that's overly optimistic.
I mean, should aim high.
That would be amazing.
It's still like doubling.
Yeah. No, but it's true, yeah.
So.
Well, maybe that's a great segue, unless we have any more questions on the phone.
We do have just a couple quick questions,
Okay.
and then it's a good segue. I can conclude on presenting a bit the Outcomes for Me app, and then we can call it a day. Maybe just one comment, and maybe because we had a submission also around a few studies that are ongoing in the nation that offer free genetic testing. So maybe we can follow up in the email. There's a Healthy Oregon project that somebody mentioned. That's obviously in Oregon. I'm familiar with the Magenta study run at MD Anderson, yes. Which actually, if you qualify, you have to qualify for the criteria for testing. Then they're offering genetic testing for free too. So there's a few of them, at least for people, if they feel that's really what's getting in the way. I do want to emphasize what you said is we are at an age where you should be able to get, if that's what you need, to get tested, and financial should not get in the way. Maybe just two quick questions. I'll say both of them, that way you can address them. One question came, what about the ATM gene mutation, so specifically on ATM? And then there was a question around understanding, and I think you mentioned it, but the link between pancreatic cancer and breast cancer in the family.
Mm-hmm. So I think, ATM is one of these sort of moderate risk genes, which is known to increase the risk for breast cancer by 2 to 4-fold. I think ATM is a gene that we struggle with in terms of what are the risks for a second breast cancer when someone has a first breast cancer and is found to have an ATM mutation. ATM probably accounts for about 1% of breast cancers, is what the studies show, maybe 1.5% of breast cancers. About 1% of us just carry an ATM mutation anyway. And so I think with ATM, because it's so prevalent in the general population as well as in the breast cancer population, my hope is that with ATM we'll learn more quickly what all of the associated cancers are. And what the risks are. So currently, if we know someone has an ATM mutation, we do start screening them at an earlier age, and we do screen them with MRIs and mammograms, alternating at 6-month intervals. And so in terms of how early do we start an ATM, that's variable, and the national guidelines are to start at 40, but if there's a family that has an earlier breast cancer, then we would start earlier. And so that's for ATM. And then the pancreatic cancer and breast cancer, the connection here is that there are a number of genes that are associated with both the development of breast cancer and an increased risk for pancreatic cancer. But again, the pancreatic cancer risks are increased, but not to the same magnitude that the breast cancer risks are increased. And so genes that are associated with both are genes like BRCA2, PALB2, which works very closely with BRCA2. ATM is actually a gene that's associated with both risk for pancreatic cancer and breast cancer. And a lot of this this connection has emerged because in studies looking at individuals with pancreatic cancer and testing all of them for a mutation, the most common things that you find are, so first 8 to 10% of people with pancreatic cancer will have a inherited susceptibility or germline mutation in the cancer susceptibility gene, and the genes at the top of the list are BRCA2, followed by other genes in the same DNA repair pathway. So that's the connection there, and that's why we're making that connection. But it certainly does not mean that a woman with a BRCA-associated breast or ovarian cancer is going to develop pancreatic cancer, or that her relatives will. It does not mean that. It means that for those people in the family who have the mutation, that it can be another factor, and they may be at an increased risk for the development of pancreatic cancer.
Great, thank you. So before we conclude, I do want to address the question we got, and we'll follow up with the link for people that are interested. So on the Outcomes for Me breast cancer app. So the actual app, and you see here, is essentially what we've done. We've been working for the last few years with various evidence-based bodies, in particular with the National Cancer Center Network. They issued the clinical guidelines for breast, and as we've talked earlier, also they have their guidelines for genetic testing and others. So what the app provides, it's a way to personalize to your diagnosis information on treatments and the treatment options, including drug information, all of it expert validated. Clinical trials, so we use the underlying clinicaltrials.gov to do that. You can see the location of trials you are potentially eligible to that are close to your physical location. So we try to facilitate that. We have a symptom tracking tool. We will be rolling out in the next few weeks a symptom management part too, that a lot of people that are using the app have asked us for. And then there's been news updates and sharing. And what we've done today, as I mentioned at the opening, is we have incorporated genetic testing. So we've incorporated the first phase of it, which is specifically to test, to check whether you or your family meets the BRCA1/2 testing criteria based on the NCCN guidelines. So you can find that by going to the profile tab of the app and click on genetic testing. It will take you through a questionnaire that then will determine if you meet the testing guidelines for BRCA1/2. What we are working on is the rest of the genetic panel. So as Dr. Rana mentioned, there's much more than just BRCA1/2. So we will be incorporating all that, including ways to get access to content and counselors and ability to take tests and obviously follow up on it. So again, we'll be following up with this, via the thank you email for those that, are interested in this. We're very much interested in getting your feedback. We continue every couple of weeks. We issue an update with the latest and including new features. So as Lori mentioned and Dr. Rana, our goal is really to empower people with information so that they can not only be part of the discussion, but also drive the discussion. I think that would make everybody in a better place, including the entire healthcare system. So with that, let me stop here and we can go back to the main video. And we should probably conclude this stage. So first of all, I want to thank Lori. I think, the idea of hosting this webinar together came out of a coffee place where we were saying about, let's do something. And then this was just a few weeks ago. And we said, okay, we can plan something that it's in 3 months, or let's try something and see if people are interested. Then we'll see if people would be willing to kind of get some of the technology glitch. So I think, we'd be looking forward to your feedback on this. But, we wanted to try things like this where it could be a discussion. I want to really thank, and, we want to really thank Dr. Rana for making this happen. I mean, we can't host something like this without you. So, want to really thank you for your time and sharing this. And with that, I suggest we, and thank you for those of you that are just sending comments. Thank you here. I just got distracted by the comment. Thank you very much. With that, Lori, do you want to say a few words?
Just thank you all so much for participating. And like Maya said, we look forward to your feedback, and we hope that this will be the first of a series of conversations with researchers and physicians who can help us all understand what is going on in all of the developments going forward. So I hope everybody has a good evening, and thank you so much for participating.
Thank you for having me.
Thank you.